it's very difficult, to talk about abdominal pain in general because there are so many diseases, but I will try to give you some highlights on specific diseases and the general treatment of this condition. Of course, what is pain is a multidimensional experience, including several coexisting components, so sensory discriminative, affective motivational, which is very, very important when we talk about abdominal pain, and cognitive evaluative components. When we talk about abdominal pain, we have to talk about neuroanatomy, because it's very important to know that visceral pain is the most common cause of abdominal pain. We'll talk about this later. And fiber C are strongly implicated in the transmission of visceral pain. What we know is that when we have pain, also abdominal pain, we have a modification of the neurotransmitter in our brain, and this is very important because we have a connection, a very strong connection, the intestine with the central nervous system, and we have to know that many substances like cytokines, inflammatory substances, are able to cause abdominal pain, but we have also to consider postsynaptic receptor and presynaptic receptors, because if we know what are the mediators of pain and abdominal pain, we easily understand why we can use we can select an analgesic instead of another, or even the use of antidepressant, for instance, when we talk about IBS. So abdominal pain can be a challenging complaint for both primary care and specialist physician, because if we ask people, about 75% of otherwise healthy adolescent students refer abdominal pain at least once in their life. So it's very common symptom. And the most common cause of abdominal pain is visceral pain. And considering visceral pain, we have several conditions able to cause pain: mechanical, chemical, stretch, contraction, traction. And even the localization of the pain is very imprecise. As you can see here, it's very difficult sometimes just visiting a patient, understand where is the cause of pain. Then we have to consider referred pain, which is very important. If you talk about liver, gallbladder, you can see here you may have a referred pain which confuse sometimes, the whole picture. We know that mesenteric plexus is very important for visceral pain, but from this picture, what is missing? Is missing the inside, the interior part of the gut, which is composed by the gut barrier and microbiota. You have seen these slides here showing that we have an increasing concentration of bacteria composing the gut microbiota from the stomach to the colon. And here you can see the gut mucosal barrier, which is made of microbiota, the enterocytes, the goblet cells, very important in the production of mucins, the Paneth cells, and the Peyer patches, which are made by macrophages, lymphocytes, and dendritic cells. Of course, we have a balance of the gut microbiota maintained by the action of protective factors and adverse factor. You see the protective factor, gastric acid, mucus, normal peristalsis, and adverse factors, we may have some condition related to reduced gastric acidity, hypomotility, anatomic anomalies, and so on. When adverse factors overcome protective factors, we may develop a situation called dysbiosis, which may lead to the gut microbiota-related disease. So what is the main condition here caused by dysbiosis? Is the SIBO, small intestinal bacterial overgrowth. which is a clinical syndrome due to the abnormal bacterial proliferation in the small bowel. This condition is associated to, those are other conditions. As you can see here, post-surgical blind loop, coloning diverticula, and small bowel diverticula. And the consequence of SIBO is small bowel carbohydrates fermentation with the abnormal gas production, which is a cause of pain. Here you can see all the causes of abdominal pain by location. You see how many causes of abdominal pain we may have. What is interesting is that about half of those causes are related to a gut microbiota imbalance. I work in the emergency medicine, emergency department, and we see a lot of patients with abdominal pain. Here you can see what are the main causes of abdominal pain in the emergency room. As you can see, most of the cases, 22%, are non-specific. Non-specific means IBS, SIBO. But then we have appendicitis is second cause, diverticulitis third cause. All diseases related to gut microbiota imbalance. Of course, I cannot talk about what we need to do for the final diagnosis. We have so many tests to do, the lab test, lab exam, and instrumental examination. For example, for SIBO, we have the breath test. This is just to show you that when we talk about abdominal pain in the emergency setting, the best technique is the CT scan of the abdomen, because we have to exclude, surgical causes or severe causes of a life-threatening condition of abdominal pain. Then we have all the time, to study with breath test, sorbitol breath test, glucose breath test, and abdominal ultrasound and all the other techniques. How abdominal pain is treated? Of course, it's very easy when we have acute abdomen because the treatment is surgery. But when we have non-acute abdomen, what do we have to do? We have to consider two different options. So the medical treatment may be etiological or symptomatic. When we talk about the etiological medical therapy, we have to consider the disease we are talking about, of course. If we have inflammation, steroids, immune suppressant, biological therapy, and so on. When we talk about gut microbiota, we, of course, have to talk about antibiotics, probiotics. Antibiotics, we may select a topical therapy like rifaximin or systemic therapy. For instance, metronidazole, fluoroquinolones. Of course, it depends on the condition. If we talk about diverticulitis, we will select a systemic antibiotic. If we talk about SIBO, we can choose a topic therapy. Of course, probiotics, we have many probiotics on the market, and we have so many studies. It's very difficult to understand which is the best probiotic we can use. But I would like to focus your attention on the symptomatic medical therapy. Because when we see a patient, especially in the emergency setting, with abdominal pain, we have also considered analgesic therapy, because based on the World Health Organization guidelines, if a patient inside the hospital has a pain from 0 to 10 scale, upper to 3, we have to treat pain. So we have to consider also analgesic therapy. And I would like to remember that, to remind you that we have always measured pain. So we have to use scale. The pain is from 0 to 10. What is the intensity of pain? This is very important because we have to understand whether we have to treat the patient with analgesic therapy, and we can evaluate the response, the outcome of our therapy on that patient. So In about 100% of the ER around the world, abdominal pain, acute abdominal pain, is always treated by NSAIDs. And this is a big issue and also a big problem, and I'll tell you why. So, NSAIDs, was it true? They are widely used in the ER. They are endowed with the high gastric toxicity, then require concomitant PPI administration, and they impair platelet function. The last point is also very important because when we see a patient, especially in the ER with abdominal pain, we don't know whether this patient will need surgery or not. So if I treat this patient with NSAIDs and impair platelet function, this could be very harmful for the patient. And then I have to consider that NSAIDs, the toxicity of NSAID is not confined only to the stomach, but there is a specific NSAID, gastroenteropathy. As you can see here, NSAIDs are able to cause significant ulceration and bleeding in the small intestine, not only to the stomach. And there is a specific issue on the enterohepatic circulation of NSAIDs, which is a key component of the mechanism of damage. So after absorption, and we will see it later, NSAID can undergo glucuronidation in the liver, and then they are secreted into the bile. And what is interesting at the glucuronidase, beta-glucuronidase is processed by bacteria, so by the gut microbiota. It's a specific effect of gut microbiota on NSAIDs. So here you can see how does it work. So after you administer NSAIDs, what happens is you have the first damage on the intestine is the administration, the absorption of NSAIDs. After that, NSAIDs go into enterohepatic circulation. They go to the liver, they are processed by the gut microbiota, they go to the liver, and they are secreted a second time by the bile, and they go back to the intestine. And usually when we give NSAIDs, we associate PPI. And what is interesting is that PPI offer no protection to the lower small intestine, but exacerbate NSAIDs-induced small intestinal lesion. So, and here there is a specific role of bacteria in this process, and specifically bifidobacteria. The loss of bifidobacteria associated to the administration of NSAIDs is responsible of the increased damage of the small intestine by PPI treatment. So just to say that this biosis is the key point for the development of NSAIDs gastroenteropathy. And this is a very big issue because we have never considered this when treating patients with NSAIDs. But NSAIDs have also a strong effect in reduction of lactobacilli and reduction of bifidobacteria in the gut, which means impairment of luminal pH, permeability adhesion, mucus production, which is very important, and immune system modulation, while the impairment of reduction of bifidobacteria is associated with the impairment of intestinal motility and local immunity. So mucus production, reduction of mucus production is very important, very, very big issue, because the mucus is not only produced to the stomach, but also to the small intestine and especially in the colon. So mucus thickness is maintained by a balance between synthesis, secretion, and degradation. And the administration of NSAIDs is associated with a strong decrease of mucus. And mucus is important to keep away bacteria from the epithelial cells. As you can see here from these slides, we have bacteria very far from the mucosa because of the action of the mucus. When we have impairment of the mucus, we have bacteria coming in contact with the enterocytes, causing diarrhea, and pain. And of course, NSAIDs are a very frequent and main cause of the leaky gut. And we have heard before about the importance of the leaky gut on diseases, which is not confined only to epithelial cell, but also at the mitochondrial membrane levels of enterocytes. So when we have a normal tight junction, we have a normal intestine. When tight junction are completely open, we develop this condition called leaky gut, which is a frequent cause of pain. Of course, we have heard before by Giovanni Barbara that a patient with IBS have a leaky gut. Most of them have a leaky gut, which is, of course, a cause of pain. Any analgesic safer than NSAIDs? So if we cannot use NSAIDs in the acute phase, what kind of drug we can use? One of them is a paracetamol in abdominal pain. This is a study done in the emergency department in patients with undifferentiated abdominal pain. This is a study using a randomized study using paracetamol or iosine butyl bromide, which is a spasmolytic. As you can see here, the results very interesting of this study, because while we can imagine that the association of paracetamol plus the spasmolytic iosine butyl bromide may be better than paracetamol alone, this is not true. So the best results on pain, on abdominal pain, was obtained by using paracetamol alone. And in the same study, the use of rescue analgesia was similar among all groups considered. Most of the patients, most of the physicians believe that the treatment of abdominal pain may may affect the diagnostic accuracy of the abdominal pain. This is not true. So we can use tramadol or paracetamol, and both of them do not affect the diagnostic accuracy. With paracetamol in abdominal pain, we have many advantages compared to NSAIDs. First of all, paracetamol administration does not require concomitant treatment with PPI. Secondly, does not impair gut permeability. And last but not least, does not impair platelet function, which is a very important issue. This is why this is the Italian intersociety recommendation for the management of pain and abdominal pain in the emergency setting. In the statement F, as you can see here, pain relief and the use of opioids in patients with acute abdominal pain do not increase the risk of error. So we can also use opioids, and but we have to consider when we use opioid that in the acute phase there is no problem in the administration. There are no specific side effects. Even in acute pancreatitis we can use opioids, but in the long term we have to deal with the narcotic bowel syndrome, which will precipitate SIBO and other conditions. So we have to be very careful. We can use opioids in the acute phase, but we should be very careful in the chronic use. So we can use only analgesics. This is a very interesting study on gelatin tannate in patients with abdominal pain and acute gastroenteritis. So gelatin tannate provides a mechanism protection of intestinal mucosa and prevents the increase of intestinal permeability, very big issue. This is a study on CACO2 cell permeability of incubation with Salmonella typhimurium. As you can see here, the concomitant treatment with gelatin tannate decreased the intestinal permeability of those cells. And this is a study on acute gastroenteritis and abdominal pain in patients treated with gelatin tannate. And as you can see here, this is the number of bowel movement per day, and this is the pain score. Of course, at time 1, after the administration, the patient had a very high number of bowel movement and pain. At day 2, there was a decrease of bowel movements and also pain, and day 3, a disappearance of bowel movement and pain score. This means that sometimes, we have to treat patients with the symptomatic therapy and also the etiological therapy. And we can combine of course, those two lines of treatment. So, in conclusion, what we can say in general, that abdominal pain is very common among general population. While abdominal pain may recognize several causes, in about half of the cases, there is a specific role of gut microbiota. This is a very important issue because all people interested in working on abdominal pain have to know the role of gut microbiota and the gut mucosal barrier. Of course, the clinical history, physical examination, lab tests, and instrumental methods allow us to formulate the final diagnosis. Considering treatment, we have to provide etiological therapy whenever possible, when we know. Of course, if a patient has a gastroenteritis, we have to treat the patient with the probiotics at the beginning and rehydrating therapy. If we have a specific bacteria, we have to treat the patient for the bacteria. But in case of the abdominal pain of unknown origin, especially in the ER, or in patients in which the etiological therapy is not useful to cover pain, we have to consider the analgesic therapy. And the analgesic therapy, the first is paracetamol that we have to consider, and the second, the opioid, while we should always avoid the use of NSAIDs as they are a cause of NSAIDs gastroenteropathy. Thank you.